Hello, geeks. This is Brian Kui from medicalcodinggeek.com. We are continuing not my interview, but Norma's interview with me for her assignment in her medical terminology class. So expect in the next segment of this nearly 3 hour interview. In this segment, she really asks me one question, and I just kind of go on for about 30 minutes about what I do as a clinical validation auditor. Now, what you will get out of this discussion is an understanding, somewhat of a brief understanding of diagnosis related groups, understanding of severity, understanding of resource consumption, the revenue cycle process, the importance of documentation, and a lot more, because I'm pouring out everything that I have done for the past 12 years in clinical documentation integrity, and also my past 3 years as a clinical validation auditor. So before we get into the next segment, I do want to make a disclaimer that this is a recording of a student interviewing me for her assignment. I would not suggest you take this video and submit this as an assignment. That is considered plagiarism. As an instructor, as a former instructor for a health information technology program, I would hope that students get inspired to do the same thing that Norma did and step out of their box and reach out to professionals. Not just me, but everybody else. There's people out there, as long as you keep on asking, and show interest in what they do. And when you show interest, they will be more than open to share their insights about what they do as a health information technology, medical coding, CDI professional. So please use this as a, motivating factor to get an interview just like this. I am more than willing to do interviews with other students, but please do not use Norma's work as your work. So without further ado, here is part 2 of Norma's interview with me. Enjoy. All right, so let's get to you, Norma. You have questions you want to ask me. I'm glad you're doing this, because I want to show people that, look, it's not about just sending the questions and having the professionals' answers. I'm glad you crossed over and made the connection to make this happen. Because in order for you to do this, you have to do some work, and I was willing to work with you to get this done. So you have some questions for me, and I'm gonna answer them. It looks like it's already set up here. Like, it tells you everything. So I'm gonna turn it to you, and you take over.
You can see the copy too.
I can see the copy you gave me. I have it full blown up over here.
Okay. All right. So, Brian, can you share what title you hold right now?
Right now, my title is Clinical Validation Auditor.
Okay. And what do you do there?
I am, what I do is I work for an organization that is not a hospital based. So I used to work for a hospital, but then I got hired by this company that contracts with insurance companies, major insurance companies, to where the insurance companies contracts with this company, and this company that I work for has auditors, right, that will audit inpatient claims to make sure that the codes that the hospital is assigning is, number one, clinically validated, and number two, also uphold to medical coding guidelines.
Okay.
Right? And what happens is that I will review cases nationwide. I mean, this is one of the biggest perks that I've ever had, because for 12 years previously, I was a CDI specialist. And for 12 years, I only focused on reviewing records for that healthcare system. So when you work for a hospital system for 12 years, you understand what the population health is for that community, what it looks like. And you also get used to how the physicians will document. You
Mm,
learn patterns, you understand trends over 12 years. I mean, you see a lot. I mean, I've worked for a hospital that was level 1 trauma center. I had dealt with open hearts, burns, oncology, med surge, neuro ICU, trauma ICU, cardiac ICU. Like I've seen them
it
all.
was broad.
Very broad. Like my repertoire in coding has increased like over like really big. Like you give me a case, I will know the ins and outs for every guideline on the inpatient side, right?
Yeah.
So when they hired me, that was one of the biggest perks. When I interviewed for this clinical validation auditor, is one of the questions is what kind of coding did you do? I said, well, I list them all. I'm like, boom, boom, the same thing that I did. What boom, 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 boom. And so to prove that, they asked me questions on those different specialties. Can you tell me about sepsis? Can you tell me about encephalopathy? Can you tell me about congestive heart failure? And like when they ask me these questions, it's not like I'm trying to answer a test question. I knew the
Mm-hmm.
answer, and when you know the answer, you answer based upon your experience. Like, here's my experience
Okay.
on CHF. Here's my experience on sepsis. Here's my experience, what we did. Like, be truthful. This is what I am used to doing, because maybe the organization might be different, and you're willing to kind of cater, or not cater, but mold into what the organization wants you to do with that certain, condition, right? And so on a daily basis, what I'll do is I'll review claims. I'll review claims from these insurance companies that wants us to review these hospital medical coded charts. And I'll look at them and I say, okay, we have policies that we need to look at. And if it doesn't, if the certain condition that I'm trying to audit for does not meet the criteria that the organization and the contracted company is looking for, then that leads to a denial. Like, okay, I'm gonna, like, an insurance will deny the if you, let's say for example, the hospital will, I don't know, they want to ask for this certain amount, right?
Mm-hmm.
But then after my review, it should be this amount.
Mm-hmm.
So I will write a denial letter saying, hey, this is what I found, this is where I found it, this is why I disagree, and because of my disagreement, we need to change the claim from here to here, and you need to give the insurance money back because you over
Adjust
build
or over.
you
Yeah.
overbilled for that claim. And so we are now asking a reimbursement, because it's not to the fact that it's not that they did not treat it. In medical coding, the biggest thing that is very important is the documentation by the physician. If the physician is not documenting well enough to support what they're treating, then, if they're not willing to support what they're treating, then why are they getting reimbursed as such? Does it make sense?
Right. Yes.
Okay, so you're looking at, like, I think I got it, but the one word that I can tell you is severity. How severe is the patient's case? Okay. If a patient is really sick, they'll be really sick. But if the
Mm-hmm.
documentation does not paint the picture that the patient is sick, like, okay, the patient's sick, but the doctor writes, and maybe is this sick, you know?
Yeah.
Okay, you see what I'm saying? So when you translate that into money, well, patients should be this sick, but by documentation, they only wrote it like this. If you're trying to write a movie, like, you have a grand idea of this movie, but then you write the movie, it's like a B-listed movie. That's the
Yeah.
difference. It's all about documentation. And so that's what I do as I review documentation. I make sure also I look at the conditions that are coded are supported. You know, for example, a patient could have acute renal failure.
Mm-hmm.
But then when you look at the renal labs, BUN creatinine, GFR, they're normal. Patients urinating just fine. Where's the renal? Like I would yell in my office. My desk is right here. Where's the renal failure? Where's the acute renal failure? Same thing, like, for example, encephalopathy. Encephalopathy is like if you have confusion, you have altered mental status, right? But then when you look at the chart, patient is awake, alert, oriented. Hello, where is this patient's encephalopathy? You know,
Yeah,
and
it wasn't documented anything about that, right? It was
yes,
just,
yeah, they'll document the condition, but nothing would support it. Nothing would support it.
mm,
And one of the biggest downfalls in coding is they're taught whatever is documented, you should code it. Just so you know. This is what's happening in the industry. They're being taught whatever the doctor documents, the coder will code it. That's one thing
mm-hmm.
when you get into the program, that's one of the biggest ingrainments that you'll see. And so I've been out there, look, you can't, I mean, it is yes a coding guideline, but you have to give a little bit of leeway to make sure that the patient truly has it. That's why you take these courses, to make sure to fully clinically support what you are assigning as a medical code. So it's like I've seen cases where the patient has sepsis and the patient's not even febrile. There's no, like the infectious disease doctor would say no sign of infection, but in order for you to have sepsis, you must have an infection. So that just automatically negates it out. And you see the doctor just automatically every note, sepsis, 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 sepsis. So what's the coder gonna see? Sepsis. They're gonna code it. They're not gonna do a deeper dive into the chart to make sure and ensure that the patient has sepsis. Why? Because most coders feel like, I'm not the doctor. I don't make those clinical decisions. I don't code from, laboratory reports. I don't code from radiology. I don't make that decision,
Mm,
But in the end, let me tell you something. When they receive my denial letters, who do they blame? The medical coder. so you see where I'm getting at. It's like, coding clinic gives this this guideline on, okay, whatever is documented, it's coded. Another thing that's also very important is that if you have questions about it, you don't make the decision, you place a query, you ask a question to the physician. That's where CDI came about. It's like, if you're only limited to what you documented, but if you use your clinical judgment, okay, you can't code from clinical judgment. You have to advise the physician. You have to ask the physician to make sure, does the patient really have this condition, or is there a condition that I see clinically but you could document? That's something that can happen as well. So
it's like it has to be specific, right? Like
yeah,
physicians have to be specific in what they document, right?
yeah, like
And
it's very,
it's not like, it's like I could see how they could blame a coder, but I mean, like you said, you can't do that. There's you can't document something that isn't really there, right? Even
yes.
though the physician will say, well, I thought it was a given. I wrote this and I thought it was
Yeah,
a
yeah,
given,
yep,
right?
yep. That's usually the normal response. Like, I thought I documented that. Like, they'll go around actually documenting the diagnosis, right? But they'll put everything clinically. There's two ways of doing it. They'll put everything clinically, and they make us want to assume that the patient has that condition. Like, we were trying to
Mm-hmm.
read their mind.
Yeah.
That's one thing, and the other one is that if they're documenting it and then there's nothing there, those are two opportunities. Like, it's not supported. That's where I get
Right.
in.
Yeah.
So the CDI and the hospital side, what they'll do is that they'll review things that are supported. They'll look at the labs, the radiology, the nursing notes, the ancillary notes, but the physician is just not documenting that. Maybe the physician doesn't see it, or they haven't documented, or, as you mentioned, they're making the assumption that the patient has it and it's all there, but they didn't finish the work and say this patient has this diagnosis. And
Because
so,
it's not
as
your responsibility to look at like lab results
yeah,
and then a few words here and then plug in the things together, right? It's not your responsibility,
Right. The
right?
coders, it's not the medical coder's responsibility, because all they're doing is when the patient leaves, when they're discharged, the coder is just going through, because they're based on productivity, right? They don't have time to, go through the
Okay.
whole entire chart. And so what they'll do is that they'll review the chart and they'll just bam, 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 codes, next case, bam, 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 next codes, next case. And so that's medical coding. But what CDI does is that they do the work that the coders cannot do, like reviewing
Okay.
the clinicals, reviewing the labs that the coders cannot assign, and they formulate the questions for the physician so that the physician can document the condition. And so that way the coder can take the documentation and assign it. You see, so that kind of closes that loop,
I
you
see.
see. So that's what I did as a CDI, is
Oh,
like,
okay.
we were a big resource for the medical coders. The coders were also a resource for us, because we did, like, you could have the condition coded, but if you don't code it the right way, ultimately it's just gonna be a mistake on the CDI side, you see. So like, you have to have a certain flow when you're doing
Right.
it, right? There has to be, like, everything has to be correct. The physician has to document correctly. The CDI has to um, recognize the documentation and code it correctly. And then
Mm-hmm.
the medical coder has to take from the CDI and make sure that it is corrected. And there's no squabbles in between. Like, there's no disagreements. Like, okay, can we agree that we can move on with this case based upon the documentation by the physician? When everything is cleared, then that's where that's where the code, the medical codes, the case, the account can be sent for billing. Okay. Now,
Okay.
where do I fit in? Is after that case has been discharged and billed, okay, it
Mm-hmm.
goes where? It goes to the insurance, right?
Okay.
Okay. So this is revenue cycle. You'll learn that in reimbursement methods. Okay.
Okay.
All right. Your reimbursement methods class. So the revenue. So one thing you have to understand is the revenue cycle process. So
Okay.
after the patient has been discharged, the codes are assigned. They send it to billing. Billing sends it to the insurance. Okay. So that way, why? Because they need to get the money, right? They need to be
Yeah.
reimbursed these services that they contracted between the insurance and the hospital organization. Okay. And then the insurance will, write the check. Okay, good. Here's your money. Okay. Here's your money to reimburse you for the services for this, for one of our clients who has the insurance, right? Because when you have health insurance, you go to insurance and you pay a certain, deductible premium, and the insurance will pay everything else to cover for
Mm-hmm.
your incident. Correct? All right. So where do I fit in? I'm on the insurance side. I switched over, as most people in the industry call it, the dark side.
Oh.
Like the Darth Vader, like the dark side. The
Yeah.
hospital supposedly is the
A
force.
good one.
Yeah, the good one. And then I switched over to the dark side. I like the dark side because I like to see both sides.
Yeah.
I like to see both sides, and it's very interesting because I like to widen my scope. Of especially with the revenue cycle process. I can now speak on the hospital side. Now I can speak on, to a certain extent, the dark side, because if I talk about this publicly, my company will be like, hey, that's a conflict of interest. But yeah, that's important, is that I see both sides. And so what happens after the insurance write the check, what happens is that the insurance will have a certain database of the cases. Okay.
Mm-hmm.
And they'll see, like, okay, you'll learn this in medical coding. What they work with is the MSDRG, which is the diagnosis related group. When you
Mm-hmm.
code one claim, DRGs, diagnosis related group, I see you're writing. And then what happens is that claim has a DRG. Okay. That DRG contains how long a patient should stay in the hospital, which is the length of stay, LOS. And then another thing called relative weight. Okay. So relative weight is a certain number, and you'll learn this when you get into coding, is that it's a number that determines the rate of reimbursement. It's initially
Okay.
created for Medicare, but insurances also apply this method too. Okay. So depending on that relative weight, it determines how much, the insurance will give to the hospital organization to pay for the patient's hospital stay. Okay. And then, so eventually down the line, those DRGs will be populated in reports. Okay. And that insurance company will send it to my company. Okay. And then my company will look at that and say, okay, because when you look at DRGs, you could see the ones that have potential opportunities where you can make a denial on. Like, for example, if, like, as I mentioned, the severe cases, those are the ones that we really look at, because, you want to make sure that they're really severe. We don't pick the ones that are non-severe. We want the ones that are severe. Okay. And so certain conditions have a certain level, like pneumonia has 1, 2, 3 levels in DRGs. You'll learn this later. I'm not going to get into it, but there's severe pneumonia cases, there's less severe pneumonia cases. And so when they send over the report to us, we'll look at, all of their pneumonia cases, for example, and say, let's look at the ones that have this DRG, which is severe, and maybe the one that's less severe than that, but we're not going to look at the ones that are just pneumonias. We want pneumonias with more other comorbid conditions, as they would call it, like other conditions that the patient has on top of the pneumonia that we need to look at, that I need to look at. For example, like pneumonia with respiratory failure, pneumonia with I don't know, hyponatremia is a good one, right? So when I get, so what happens is that they'll take those DRGs, will request those specific records with those specific DRGs from the hospital, and then the hospital will send, not the insurance company, the company that I work with, that we're contracted with insurance, right? And then that company will then disseminate it out to the auditors. Okay. And then I will get the reviewed case. I will look at it. I will make a determination if all of the conditions that are listed, that were assigned by the coder, okay, are legit. I'll look at the principal diagnosis. Is the principal diagnosis, should it be the principal diagnosis, or should it be something else? Right. I had cases where the patient presented with one condition, but also had another condition, but they treated the second condition a little bit more than the other one. So I switch it, you see? So it's a change in principal diagnosis. And so as a result of that, the reimbursement drops, because if your focus is on treating this one condition, not the other, why are you getting reimbursed for a condition that they didn't even look at? Or not the fact that they looked at, they treated less compared to the other one. Like if this secondary condition required an operation, this one didn't. This one required to go to the OR. So why are we getting reimbursed for something that didn't require an OR visit? Because the resources to bring a patient, to bring them to the OR, preoperative, perioperative, postoperative, anesthetic care, all of the things that you will learn that goes into assigning a diagnosis. What's the word that I would say? Resource consumption. A diagnosis will have resource consumption. Because if you have pneumonia, what does it require? You have to go to the ER. You have to have a chest x-ray. You need to have oxygen. You need to have antibiotics. You need to have nursing care. You need to have respiratory care. You need to have a pulmonology consult. You need to have an infectious disease consult. You see where I'm getting at here? The list of things that are required to take care of the patient just for a pneumonia.
Yeah.
You see, so that's the thinking that I have in my head. That took me 12 years to finally make it click. Resource consumption. That's the one thing that I always talk about when you're looking at the revenue cycle in hospitals. So I review the case. I make a determination if there's a need to deny the claim. If there's for me, okay, this needs to be looked at because I don't agree with what the coder said or what the coder assigned. So I'm going to send a letter explaining what I found, why I feel I don't agree with it. Here's some evidence to support it. On top of that, here's some references that you need to look at that would back up what my findings are. Okay.
Okay.
So that's where I'm at in my position. After that, that letter goes back to the hospital. Okay. It's called appeals. They'll receive the denial. They have a certain amount of days. I think they have like 30 days, 30 to 90 days. I had a check up with an appeals friend about this, but 30 to 90 days to respond back. Okay. The whoever the denials coordinator at the hospital will look at that. They'll do the same thing that I did. They'll look at the stuff. They'll look at the case. They'll look at what I did. They'll make a determination. If they don't agree, they will rewrite another letter, right? Sending it back to our company. Okay.
And this is all mailed?
Yep. It's all mailed. It's all mailed. So you see, like, let me explain that let me explain this for a second. I'll get to your point when it's all mailed. So when it gets to us, then we'll look at it. It's not just us. There's like a full team, like a medical team, a coding team, a nursing team that will look at it and make it a determination, because ultimately it's the insurance say if we agree or disagree with the disagreement on our disagreement, you know. So that in itself is an appeals process. So it's either it's a go, we'll allow it, or number two, you got to pay us back, buddy, because we don't agree. What is lost in the appeals process is, as you mentioned, it has to be mailed, right? Mailing takes time, right? And so when you increase the amount of time, let's say, okay, so if your patient is discharged on this certain date, okay, you send it to the insurance company to get it billed. Normal cases, they'll cut the check and give it to you, right? But because there's a certain discrepancy, there's a disagreement, well, guess what? The time to get the true reimbursement keeps on going. You see? So your cash flow is delayed. Like you're supposed to be paid for these services, but you could take out, like as I mentioned, it takes you to respond 30 to 90 days. I mean, you're already extending the money that you're supposed to have received 30 to 90 days out. And if they don't agree, that's another 30 to 60 days out. And there's a second appeals process that you can go for like 6 to 9 months before you finally get your money, your true, I guess, accurate payment, right? Yeah. That is extended out for like, I don't know, 6 to 9 months. And that's just on one.
Wow.
Just on one.
Yeah, I was thinking about, like, I mean, this is all in the background, and I'm thinking, like, from a patient's perspective.
You don't see that.
You don't see that, and you don't get denied any care, right? You don't get denied.
No, you get the care, but it's like, you know, who's paying for what?
Yeah.
Yeah.
Okay.
Yeah.
All right.
Yeah. I think that answers number one.
Yeah, the job duties, right?
Yeah.
You basically like said like most of your job duties, right?
Yeah, that's it. That's all I do is I review cases. It's nice because the organization is very big. Okay. And we have so many supporting team factors. Like when you think of a team, it's like a skeleton crew, right? You have the very basics, but this organization has a lot of people for every step of the process, you know, receiving the records, doing the auditing, doing the appeals, doing the training, doing everything. There's always somebody there with a team ready to go. What the downside in most hospitals is that they don't have enough people to handle that. Normal cases for one hospital, I know for one healthcare system, one person. You see what I'm saying? Like you're going against a full like stacked team, and then they're going to this one healthcare system, and then one healthcare system has only one person.
Wow.
You see where the disadvantage is? It's like I even talk about this. I was like, you know, if you're complaining about this process, the hospitals are. Where's the people that you're trying to? Where are your resources trying to match up with this? You don't see that.
That's crazy.
Yeah.
So just to understand the company that you work for, it's basically a company that is on the insurance side, or
It's
is the insurance?
no, it's not insurance. It's not an
Okay.
insurance. It is a, how would I say it?
Is it like a third party, or
It's
is
like
it
a third party. Yes,
like a
it's like a
subcontractor?
not a subcontract. It's a service. It's its own
Okay.
service where they would go to insurance companies and say, "Hey, look, we'll look at your claims and help you recoup. You make sure that your payments are accurate. The payments that
Okay.
you receive are accurate. I don't want to get into like, trying to recoup money because that's not the way
Hmm.
it should be.
Hmm.
It should let's make sure that the payments are accurate. We have auditors on our side that will review the claims on your behalf, and we will do all of the processes for you. So it's kind of like a contract job, but it's a
Okay.
service. It's like a business to business service, but business that caters to insurance companies. And so I think also they do this for retail as well, making sure that they're looking at their analytics, their data, and looking at trends and looking at the trends like, okay, these are some of the cases that based on the trends, they see the problems. And so with those problems, they'll pull those type of cases out. Okay, here are
I
your,
see.
like they'll run some data on the company, they'll look at it, they'll identify the problems, okay, and they say, okay, the company will tell the insurance company, these are your problem areas. We might want to look at that, okay, and that's where they'll take they'll look at the data, they'll grab all the patient information, they'll make the company will make the request to the hospital, and then they'll get the medical records, then we review the medical records, then we do our process to make
Mm.
sure that it is accurate, and then we go into the process of denials, appeals, and so forth, remediation,
Mm.
whatever it may be, because sometimes it would get to court, like that type of thing.
Yeah.
Well, but money is money. It's like we got to make sure that the payment is accurate.
Okay. All right. That makes sense.
Yeah, that's the
Okay.
that's a total business that I never knew about. Like you mentioned, like you never knew anything in the backside. I never knew about
Yeah.
this until I got into this company. Then I'm like, wow, there's so much. Like there's like when people work in the hospital, they're kind of like, I felt like they're
Yeah.
kind of closed in a bubble. Like when you leave that one hospital and you see what hospitals around the nations are doing, like
Yeah.
like it makes you open your eyes so much more. Like there's
But I mean,
so
when you
much
were
problem.
in the hospital,
Mhm.
you were communicating with a company such as, or
Yeah,
no?
not in my role, but the
No.
but the but the CDI department and the medical coding department, yes, they did. I mean, I haven't seen any claims. I haven't done any audits on my former employer, but
Hmm.
I have done audits on hospitals that are around my former employer.
I
Yes,
see.
you see,
Okay.
and they would, yes, receive, like I would see, not from my company when I used to work at the hospital, but other insurances like Blue Cross Blue
Okay.
Shield would do an
Yeah.
audit,
Yeah.
Humana would do an audit. They would receive this type of audit, and they would go. I would see that they would undergo this process. And so if there was a certain case, they would send it to um, the coder. They would address it to the CDI, because I remember this one case. There was one case of a patient who had sickle cell disease, right? And so when you have sickle cell disease, you have pain all over, right? And one of the biggest pain is in the hips. And so within the hips,
Mm.
it's called avascular necrosis. And so when we got a denial on the avascular necrosis, because the patient did not have pain in the hips, they did not do an X-ray. And so because of that, they were only treating the sickle cell,
Okay.
generalized pain, not the specific pain in the hips. And so because of that, the insurance company says, you're the way this looks like is just a sickle cell. You didn't do an X-ray. The doctor didn't say that the patient had hip pain. So there's nothing
What
to
if they
support it.
did and there was no X-ray? Would that be
If the patient
sufficient enough?
had hip pain, okay, and they say the patient had a past medical history of avascular necrosis, and maybe if they had referenced an old X-ray, like a previous X-ray, because sickle cell patients, they come in frequently because they have these bouts, ever
Okay.
so often. And so maybe there's another hospitalization that they had an X-ray the doctor, should have not known, but a good practice was, let's take that X-ray. If you say the patient has a medical history of avascular necrosis, let's pull that old X-ray. There's no need to do an X-ray now because we have an old X-ray. And so we're going to pull this old X-ray, say in the physical examination the patient has hip pain, and then the pain meds, you see? So that's the combination that would support it. But in this case, avascular necrosis, history, nope, hip pain, no imaging. Right? So we can't assume that the pain medication that is used for the whole body is directed toward the hips. We can't make that assumption either as an auditor. And neither should the medical coder make that assumption either. So it ultimately comes down to where's the documentation?
Yeah.
Yeah.
MedicalCodingGeek.com